question is, with this diagram, is when we implement a major reform at the federal or state level, we got to try to make it something that we're not frightened of. And today's talk will be on uh, reforming the healthcare system to create a single payer system, Medicare for all type system. First, we'll discuss at the federal level and then move on to state-based reform. And hopefully we would not create something like this, but um, you can create an administrative behemoth that's not responsive to the public. So that's the first problem I would talk about. Will it become an unaccountable administrative monster? And I pointed out to you one of the most galling, annoying administrative uh, structures in the current Medicare system. And that is this notion that we're of at full admission versus creating an observation state that creates all kinds of bureaucratic side effects and is stressful, is annoying, and is 100% unnecessary. And both the American Hospital Association and the American Medical Association, the hospitalist group, because we're especially affected by it, I'm a hospitalist. So we've all complained that this needs to be just gone. It's unnecessary, and yet nothing has happened. So truly, in the form of the current Medicare program nationally, we have what appears to be an unaccountable administrative entity that's, that has no built-in system of accountability, or it would have changed. And I think when on Thursday, when we talk about what kind of system we would want, I think we need to be pretty aware of that and try to create a system that has accountability in it. So if we're going to create a Medicare for all system in the US, the current Medicare structure just has to really be greatly modified. But also there's other threats to leadership of a single payer system. I'm not saying that Secretary Becerra's pictures there on the left, is incompetent, but he has absolutely no experience in the health sector. He's a lawyer. He was in a high legal position in California, and he sued an insurance company over some stuff, and I think he won, and that got him to be well known. But I don't think he has an understanding of what this unaccountability in Medicare is like, or the utility or lack thereof, this value-based care stuff. So he's got the position, but he's been inconsistent in his leadership. So the question is, are you going to appoint that? There's a commonly used statement in Washington that personnel is policy. And with his appointment, it became likely that we weren't going to have major change in Medicare, because he couldn't know enough about how it actually operates. The fellow on the left is Adam Boehlert, and he was Trump's appointee to CMMI. He had very few credentials. He's very young, and this is a more recent picture compared to when he was appointed to head the CMMI, which sets the future directions of Medicare. And he created a type of entity called ACO REACH, which we've mentioned a few times. It's part of one of the value-based care schemes that CMMI created. And then he almost immediately got involved in creating one and would be in a favored position. So he gets appointed due to connections with I can't remember Trump's nephew, can't remember the fellow's name. Ivanka's husband, I can't remember his name. Anyway, this is a personal friend of his, and so he got appointed to this position and took advantage of it. But that's not unique. The woman on the left, whose name is Tavener, was appointed by Obama for 4 years as the head of the entire Medicare program. within 6 months of leaving Medicare, she took a $2 million a year job as the chief lobbyist for the major lobby of the health insurance industry. Fellow in the middle is Azar. He was appointed both during the George W. Bush and Trump administrations for high positions within Medicare. He's a drug company guy. He's Eli Lilly's man. He was there before and after that appointment. And he was in the Bush administration when they created the big Part D prescription drug coverage plan. And needless to say, it's set up in a way that's quite favorable to the pharmaceutical companies. These are gross conflicts of interest, and it is what it is. So you can do this within a system. The woman on the right is the current head of the CMMI, whose history is in both the insurance and more recently the pharmaceutical industry. She had a high level cush job with very few responsibilities, but was paid a lot due to her history of going back and forth between government and high levels in government and high levels in industry. She's a power player. She's a current head of the CMMI, which again is the innovation center there, sets the future directions for Medicare. So you can unfortunately appoint people who have conflicts of interest or are cronies or are not committed, don't understand the issues in healthcare. This is a really big problem. Now nobody has a perfect knowledge of healthcare. Everybody has their own job. They see things from their own point of view. However, it's a um, sometimes the conflicts of interest and the cronyism is just more apparent than other times. So, so the second category of problems is that most enhancements of the healthcare system result directly in a tax increase when you have a single payer system. I would also argue that there's also a tax increase in our system, but it's less direct. In other words, if our local hospital for some reason adds 4 MRI scanners and has to hire all the staff to operate them. And they're there at the hospital getting paid all the time. We're paying off the money to the company that produced the MRI scanner. That has to get paid for. And so the hospital basically raises its rates. They may particularly raise the rates for MRIs, but they probably won't. They'll probably diffuse it and spread it out over everything they do. So we're all going to pay. And so if they have to raise their rates, then all the local insurers have to pay more. And the state government and the municipal government that's got some employees they're providing insurance for, those rates will go up. So basically, everybody pays one way or another. But the difference is that in a single payer system, it's right there in your face. You added a cost to the system, so somehow it has to get paid for. So let's give you the example of a growing community that is growing a lot in population. We have a lot of those in the Southwest US and in Florida and other parts, warm areas of the country where people are migrating to. And they may need another hospital. So if we had a single payer system and the currently existing hospitals in the region were over capacity and they really need another facility, you could build the facility and run it, but again, that would have to be paid for. Now, if the community is growing, presumably their tax base is growing. So it may not be that hard to raise money for it if that payment were at a municipal level or even at the state level, if the population's growing. But one way or another, if you improve the healthcare system with more technology or add jobs for whatever reason, it's either going to get paid for, or if it's a country we're talking about, you throw it on at the national level. This is also true at the state level. If the state wants to improve its facilities and you have a state-run system, then the state needs to pay, somebody needs to pay for it. On the other hand, let's say there are communities that are decreasing in population and a facility, it's just one too many facilities. It's just not that hospital's no longer being used. There'll be job loss as well, in addition to the loss of the community service. So, and in a publicly accountable single payer like system, you're going to have a lot of public input that's going to be really negative. So there will be inherent with demographic change by itself, you're building in the fact that there will be conflicts and unhappiness with whatever's decided. So when we're designing our ideal system on Thursday, or in general, if you're in a position of power later in your career, you have to be aware that things, it's almost inherent that you're going to face conflicts over having to do things that may not be popular. In the existing system, we've already talked about how urban facilities close or open more due to profitability. The hospital could be bought up by a real estate firm and closed because the real estate firm thinks it can make more money using the hospital's real estate, as we saw at Hahnemann Hospital in Philadelphia. So anyway, but this is an inherent issue that you have to make decisions based on demographic change, and they may not be popular. So every provider payment scheme has disadvantages. I think Adam Gaffney a couple weeks ago made a strong argument for global budgeting for operating costs, separating operating funds and payment to hospitals from the capital and the decision-making process for who's going to expand and who isn't going to expand. That needs to be more decided in response to public health needs. And if Hahnemann Hospital, in a single payer system, if Hahnemann Hospital was heavily used serving a poor community, a public system would presumably have kept that hospital open. Maybe found other hospitals in the suburbs to close if they were underutilized. So anyway, well, we saw that all types of payment schemes do have disadvantages. If you have an annual negotiation between a hospital CEO and the single payer system, then that's subject to mistakes. You could underfund the hospital, harm the services, or what if the hospital CEO is just incompetent and squanders the money? That problem is not only going to be the hospitals, it's also going to be the healthcare systems. If that community's no longer receiving the care they need even if it's due to incompetence only in their own administration. So poor quality administration becomes a problem for the system as a whole in a single payer system where you have public accountability and people are going to notice if things aren't going well. On the other hand, some of these, you heard Dr. Himmelstein talk about quality of care and the hassle and cheating going on with pay for performance schemes. So it seemed to me that there's more disadvantages there. With all these complex value-based care systems seem to just create a lot of administrative activity with relatively little benefit, if any, and probably some harm. For one thing, they're very complex and it's very difficult to go into. There's a lot of reasons why doctors are no longer going into solo practice or small practices, and the need to contend with these bureaucratic demands are really, really hard to do. So it's sort of pushed more doctors to become employees, a topic which we will be revisiting tomorrow in our discussion of physician unionization. Anyway, so all the decisions a single parent might make can go wrong. They can just not work out well. And then in the administration of a single payer system, you could theoretically elect an entire government that doesn't even support the system, maybe even try to take it apart. So, and maybe your government that really supports the system, maybe there was a sex scandal or some inefficiency in some other area. Foreign policy, like every government's done things in foreign policy to make them look bad. So anyway, so that kind of thing could happen. In other words, you could elect a government that doesn't support it for completely unrelated reasons, and then they could change the system in deleterious ways. Now, we've had conservative governments in many countries. In Germany, Angela Merkel was in power for many years. Cameron in England, Stephen Harper was in Canada's Conservative Party. Fortunately, single-payer systems are so popular that no matter who gets elected, they don't get demolished, basically, but they can be kind of steadily underfunded, which was what Maggie Thatcher did in England for, her 10 or 15 years in power. She just never really supported the National Health Service, and more queues were developed and there were shortages in certain areas. So they single payer systems are popular. They aren't going to get taken apart usually. I mean, I don't know of one, but they can be underfunded and not supported, and that's why after enactment, people who care and who are knowledgeable, like your group is, and I hope will continue to be, you'll follow all this after you leave this internship. Um, you're going to be in an important lead position after a single payer system is implemented in the U.S. Notice I said after and not if. Anyway, but you have to keep an eye on it and make sure it's being supported properly. So now we'll talk more about the political obstacles to single payer reform. You're going to get all this predictable rhetoric, and this will happen more before implementation. After it's implemented, these voices tend to fall away because the systems tend to be popular. But anyway, the rhetoric is predictable, and we'll have a session later on, maybe even tomorrow if we have time, where we'll talk about this rhetoric and how you respond to it. But some of it is like one size fits all, single payer system. That's a common way it's referred to by non-supporters. Or a government takeover. They want they want to create a big taxpayer-funded bureaucracy to take control over your health care. These bureaucrats who you don't ever get to meet will set up a system to ration your care so that everybody gets the same thing, not enough. And then when they can't control costs, they'll cut even more until there are queues and you need to wait in before you can even get your appendix out. And then another one, biggest tax increase in US history. So all of this is predictable, and we have to think through how to respond to that. By the way, that rhetoric is also done at the state level for those attempting state level reform. It's the same types of rhetoric. We already pointed out huge numbers of workers. If there were a single payer system implemented, 400,000 or 500,000 healthcare administrative workers would lose their jobs. Or more, actually it's more than that. I guess 1.7 million if you include the ones working at hospitals and doctors' offices. So we have to think about that, and it's going to raise objection. And then in terms of influencing public opinion, you have huge lobbies, powerful lobbies who are going to oppose it. The pharmaceutical industry is the strongest lobby, of all, the biggest one, even bigger than the insurance industry. And here's a huge insurers that are making a lot of money, and they have huge lobbies as well. And actually, I can't see the woman in the lower right, but probably just another lobby I put up there. Anyway, well-funded internal interests have these big lobbies: insurance, pharma, the medical device companies. So, for example, I pointed out in that op-ed piece about the creation of software systems, multiple software systems in the US, all of which are very costly, which are hard to leave once you're in them because there have to be all this retraining. And we hate them. All the doctors and nurses hate them. They were thrown into the market very quickly. They're terrible. And so if you swept all that away and created instead a single system that could be developed thoughtfully over a period of some years and just gave it to every doctor and hospital in the country, this entire sector of the economy, the software vendor sector, would suddenly be out of work. Their stocks would have very little value. So you have, in that case, one moneyed interest that would fight like dogs to fight that type of reform. For single payer reform, more generally, you have more opponents. Unfortunately, the hospital sector, which I certainly think would not be harmed, especially smaller hospitals that are financially problematic straits, like the hospital you heard about last week with Josh Dufresne from Josh Dufresne. But the hospitals now have CEOs who are very well paid, even the not-for-profit hospitals. They're real comfortable. They know how to contend with the system. Even when they don't run a profit, they still make big salaries. So the high levels of hospitals, the CEO suite, tend to just be real comfortable with the status quo. And they'll get their lobby, the American Hospital Association, and then the for-profit hospital lobbies called the Federation of American Hospitals. I'm sure those lobbies will fight single payer reform. So it'll upset their little comfortable niche. The tertiary care sector is pretty much what I'm mentioning, that there's a lot of money in tertiary care hospitals forming their conglomerates, merged systems, and that's all these mergers are not really benefiting people's health care. So a lot of that administrative stuff would presumably come down in a single payer system. More ambiguous is what the doctors would do. And I think at this point, the AMA has moved enough so that they would not turn out to be a major voice opposing single payer reform. It's arguable, it's possible that if it happened quickly and things weren't done to reassure them, that they might oppose it, but the AMA is changing largely due to younger people getting involved who are demanding change. And I think it was mentioned earlier in the internship that this has actually happened from their medical student section, that they've been pushed really hard, and one of their motives for listening is that their membership has been dropping and they don't want to alienate medical students. So they're listening. And I think this may seem odd, but younger doctors like you and medical students may actually have more power than if you were 30 years into your career, because they're really worried about their future membership and don't want to be seen to to alienate younger doctors. So, as I said, well-funded interests in opposition. Also, another separate issue is unfamiliarity. That in the United States, people are so used to the mess that we're facing that the idea of not getting coverage through their job and just delegating it to a system that just includes everybody, it's actually hard to explain. People don't understand it. Like that slide I had several sessions back on, okay, it's going to be universal. Everybody's in. And you have to say everybody like 3 times because people don't get it. You're in. You were born and you're a resident of the United States. You're in the system. And, you can argue about whether to exclude um, categories of immigrants. I mean, legal immigrants, there's very little argument for, but undocumented population, that can be argued. But leaving them aside, I mean, everybody else is in. And, it's hard to even for people even to get that, or even to understand this coverage is going to be really good. You're not going to have copays at all. It's like, oh, what? Like, really? Like, you sure? Like, I don't believe it. Like, I can't support that. It makes no sense to me. So this stuff's very, very unfamiliar. And even you guys, when someone asked earlier in the internship, one of you asked, well, is there really any successful healthcare program? And I was thinking that actually most of them have been really successful. And as I said, I'd rank the community health center program at the top of the list, but the FDA saved lots of lives from unsafe drugs that got approved in other countries. National Institutes of Health is paragon of research in the world. And so, you got to get people used to the idea that government can work when you make it work and when you watch and you keep an eye on it. And you support it when it's working well. All the AIDS activists working against the to modify priorities in the National Institutes of Health in the 1980s. By the end of it all, they were thrilled that there was a National Institutes of Health, even though they fought them tooth and nail to do better with HIV, HIV research. But what if there were no National Institute of Health? And, what would they have done then? So you create a government institution and make it work well. So additional political obstacles is that, especially when you get conservative governments in Britain and Canada in particular, you can have problems with those systems, and they're going to be disproportionately publicized in the United States by the political right wing that opposes change and by the moneyed interests in the US who oppose change. So if something works well in Canada or Britain, they're not going to publicize that. It's the problems that are going to get publicized. Then another political obstacle is that we talk a lot about the uninsured and the underinsured, or people who even go bankrupt due to healthcare costs. But you have to keep in mind that many Americans have very good coverage, or at least think they have good coverage. And so the devil may be preferable to the unknown. And that is very high on the list of political obstacles. Again, this would occur at both federal and for state level reform as well. So another issue is non-incremental reform is hard. So, for example, you're all out there saying, well, everybody should have good quality insurance. And that's why we want to create this single payer system. So the very first thing we're going to do to create this system is take away your current insurance coverage. And we're, of course, going to give you something we think is better, but that's an issue. Every person loses their insurance coverage to switch to something unproven. Again, enroll in a massive government program in a country founded by mistrust of government, with all these internal interests and opposing it. So these are big obstacles, but people in the United States, people are so glad to have whatever coverage they have that they're not going to necessarily welcome with open arms losing their current coverage. All right. So it's 9:38. Why don't we take a 5-minute break now, and then we're going to move on to talk about issues that are more specific to state-based universal, quote, universal healthcare plans. And we'll reconvene at 9:45. Okay? Whether it's September. So all of what we've been talking about would apply at both federal and state levels. In this second part, right now, that we're going to move on toward, I'm going to talk more about obstacles that are more specific to state level reform that don't exist at the national level or are less of a problem at the national level. So let me go ahead. So when states attempt single payer reform, they may have a friendlier environment. And I think that the movement for state-based reform is more founded out of frustration with paralysis at the national level. Since we basically had very stable, I don't know if the word conservative embodies it or neoliberal, but we've had a very stable, immutable, immobile, almost paralyzed federal government for years and years, and unusually so compared to other historical periods, and with remarkably little change. I'm going to talk about that more later in the internship, but this paralysis of federal government has led to this feeling that those who, especially doctors and people who are sick, patients who actually are sick, we've been talking about health reform for years and years, There was a big move in the 1993 at the federal level, state levels. I mean, it goes back further, even in the 1950s and 60s. Why not have everybody in the program? Truman had a plan. There was even discussion before then, before the first half of the 20th century. So it's been discussed forever, but nothing happens. So more and more frustration with nothing happening has led to a desire to get something done. And this would seem especially feasible in states that have a more progressive attitude toward many types of reforms. So, you can call them blue states, states that tend to vote more for the Democratic Party, which may or may not be willing to undertake major change. I think in the value-based care programs, you're seeing that at least some wings of the Democratic Party are not really interested in major change, but others are. And you've met with some of them. Dr. Chi and his group in Oregon are trying to create a state-based single payer system or something close to a single payer system out of this frustration. And there's, and more consensus in many states. And so one question is, what are these states attempting single payer systems? Are they going to be able to take advantage of the efficiencies in the cost control strategies, some of which are literally built into having a single payer system? In other words, every single American is included in a single payer system. Then immediately you're only dealing with administrative costs from that one insurer, not all the others. And immediately you've tremendously simplified all the administrative activity within hospitals and doctors' offices, every single care provider. So in one sweeping move, in one move, you're sort of sweeping away a tremendous amount of administrative costs. So this is built into having an actual single payer system. Secondly, and so hospitals could be paid via an annual global budget, which turns out to work really well in terms of having incentives provide the right amount of care. If they provide too much care and go over budget, then they're over budget, and that's not good. If they don't provide enough care and are referring patients to other hospitals for whatever excuse, saying, oh, we don't provide that service, go to the university, 30 miles down the road. Then the next year, when their negotiation comes up, they're going to say, well, your hospital's not full. We're going to cut your budget. So hospitals do have an incentive to have their hospitals well utilized, but on the other hand, not overutilized for services they can't safely or reasonably provide. So in some senses, the incentives are just right as compared to paying hospitals by the day when they have an incentive to just keep patients in the hospital for days and days, even potentially unnecessarily. So that kind of reform is easily implemented within a single payer system and enhances both cost control and community service. At the right here, drug prices and prices of all inputs could be negotiated. And what you have with a single payer system is a monopsony, a single payer that's buying all the drugs for the whole country, 340 million people. So that's a very powerful payer and would be in a very strong position in negotiation. If you're talking to people who oppose single payer reform, they'll say, well, wouldn't competition lower costs? Competition among insurance companies. So that thinking is looking at an insurance company as a seller of insurance policies. And they do sell insurance policies. But the insurance company also is a buyer. So they're a seller of insurance policies, but they're a buyer of hospital and doctor services and MRI scans and everything else that is provided in their healthcare policy. And with a fragmented insurance with multiple insurers, none of them are going to be positioned to sit down with a drug company and say, we're no longer going to pay 60, 80% more than all the other developed countries. We're done with that. These little, minor insurers are not going to be in a position to do that. So having a single payer can drastically negotiate down prices, which, as we pointed out earlier in the internship, is higher prices in the US account for 90% of the distinction between the high spending in the US versus the lower spending elsewhere. So it's a very important source of the high costs in the US. So Vermont arguably has come the furthest in implementing or in moving ahead with a single payer system. And these slides are going to use the word Vermont a lot, but there's nothing special. This could be any state that attempts it. And there's a few situations where Vermont may actually be worse off, but it's a matter of degree, really. So we had a progressive governor, and we have a progressive populist, and the governor had a highly effective political campaign before he got elected. He actually ran on single payer reform, calling it single payer reform without fear that it would sound bad to the two opponents. And he got to the point where about 70% of Vermont's population in repeated polls, just based on his superb advertisements that he put on television, these 30-second ads saying, we're done paying too much to the drug companies and the insurers. We want to pay doctors and nurses. That's what our plan's going to be. 30 seconds, he did it in these beautifully done ads. And he won the election. And shortly thereafter, by May 26th of his first year in office, he signed the nation's first plan to develop a single payer system called Green Mountain Care. And that made the Washington Post as a headline because no other state had done that. Both houses of our legislature passed it. The governor signed it into law. There we were, a political victory. But the question is, was the policy going to work? So in other words, there are policy obstacles to single payer reform at the state and national levels, some of which we've talked about, and then there are political obstacles. And in Vermont, we overcame the political obstacles, but then that left the policy. So what happened? 3 years later, here's the same governor, and that actually is his profile. He really does look like that. Anyway, there he is 3 years later after a big study had been done on what impacts the single payer system would have on Vermont and the finances of the state government, and he withdrew the plan and decided that we were not going to implement the plan that we had that had passed through our legislature. And I have the document, I have that analysis in your reading list. I don't know if many of you got to it, and if you read that analysis, one of the most striking features of it is that in their estimate of administrative savings, which I just talked about at the national level, how one insurer nationally would sweep away all this insurance company stuff. The estimate in Vermont was that there would be 0 administrative savings in Vermont. So we're soon going to get to why that was the case. So really, there are two types of problems in the policy part of single payer reform. And I think Dr. Malinow and Kate Tillow at 11 o'clock are going to talk especially about political and longer term other types of problems associated with state-based reform. But I'm going to go into the micro level. And I just want to say that I want to support universal healthcare reform any way I can. For those of you who've learned about Canada, the Canadian healthcare system was started in a single province in the late 1940s by a progressive leader named Tommy Douglas, and it ensuring hospital care and then later doctor care. And then that spread to the whole country. And that's kind of the model in the US among advocates for single state-based reform. Unfortunately, now the amounts of money are massively higher than they were in Saskatchewan in 1946. So there are additional obstacles that we face. And so there are basically two types of obstacles that would either be minimal at the federal level or not exist at all. And I'll just go through the two of them. One is the tax increase. And I use the word increase because it would be a big tax increase. In fact, the amount of money that was estimated to implement Vermont's plan was more comparable or more than the entire state budget for everything else. So it's a huge amount of money. And the whole point is to pay for it. We all pay in single payer healthcare. We all pay in based on our ability to pay, our income. And then when we get sick, our healthcare system takes care of us. That's the beauty and the kindness that's inherent in a single payer system. Implementing it at the state level, though, everybody has to pay in. So and that's called a tax. For publicity reasons, we wanted to call it a premium to the state insurance fund or give it another name, but essentially it's a tax. There's no denying it. It's just you want to try to make it a designated tax that goes into insurance fund and not deal with this thing out of general funds, because then it's truly a tax increase and it's a political, it becomes political every single year. Anyway, so it's that we would create a state insurance fund and tax our population to implement it. So everybody who wants to implement a single payer system, nobody's saying, well, the poor people should pay the highest portion of their income. I mean, come on, nobody's going to say that, right? So you're going to want to have the rich people pay a higher proportion of their income. So here's what it looks like. In the current system, I have current where it says very regressive in parentheses. And these are two taxpayers, both of whom work at a company, let's say FedEx. They both work at FedEx, but one of them has a high salary, it may be a high level administrator. The other one is, a new employee with a very low paying job, 20,000 a year. And so they both want to get health coverage. So currently they pay their portion of the premiums, say for family coverage. So family coverage now costs over $20,000 a year. So if they're paying 20%, that's 4,000 or a little more. So the poorer employee is paying 4,000, as is the wealthier one. That's their premium, their portion of the premium. Their employer, FedEx, pays the other 80%. As a percentage of their income, this is drastically different. Because $4,000 for somebody who's earning 200,000 is not a whole lot. It's not bad. It's a small percentage. On the other hand, for the poorer paid employee, that's 20% of their whole annual income. And they still have to pay other taxes, and housing costs a whole lot. So this is extremely regressive, and they're paying a high portion of their income, 20%. So you could have a flat tax where everybody pays the same proportion of their income. And you can see this is drastically different, where the poorer person is now down from 4,000 to only $727 a year. And the wealthier person is $7,200 a year, so 10 times more, because their income was 10 times higher. So that would be flat funding. Most of the progressive actually want it to be progressively funded. So they're going to tax the wealthy people especially. And because it seems more fair that they can handle a higher proportion of their income being taxed. So even if you take them up to 70, I don't know, 7,600, I could have made it higher, 10,000, 15,000. That's still less than 10% of their income to get fabulous healthcare coverage. Because all the single payer proposals at both state and federal level are fabulous coverage, cover all kinds of services, except cosmetic surgery with minimal copays, deductibles. So they're getting fabulous coverage. So even if you made the rich people pay 20,000, in New York, they had a progressive taxation scheme, and the highest 10% of taxpayers were going to pay $84,000 a year. It was going to be their premium to pay for their health insurance. That sounds like a lot, and it is a lot, but it's this portion of their income. I mean, they're making, some of them are making thousands of dollars every single day. So in Vermont, there's another source of income. So that's work-related coverage. But what about people who are very wealthy and who have a lot of income through capital gains and dividends through their stock holdings? So that could be taxed. That would provide more money so that everybody else's younger workers, they wouldn't have to pay for the whole thing, but people who are wealthy with investments. So that could be taxed separately just to get it more income to raise more funds for the proposal. So in Vermont, there was an 11% payroll tax on employers and a 9% payroll tax on employees. So that's kind of a little bit progressive, but it's at worst flat. And for some reason that I don't understand, which I wish I did understand, I don't, but they did not tax unearned income. And we have one of Vermont's legislators later today meeting with us, so we could ask her if there's time. Although we're on a slightly different topic, but anyway, but that would be another source of income for. So then there are other taxes that can be used at the national level that states really can't feasibly use. So in Obamacare, they had tax on unearned income for high income taxpayers. That makes sense to me. Taxing dividends and capital gains. Supplemental payroll tax, so an especially high tax on high income taxpayers. Well, a state could do that. But then you have extra corporate tax levy, usually on these big national corporations who have, for all their employees who are earning more than $1 million a year. I mean, I suppose you could try to do that at the state level, but a lot of these companies are across the country, and they could say, well, in Vermont or California, whatever state has a single payer system, we don't have any employees that are over $1 million. We could count them as an employee from another state. So states might have trouble with that one. An excise tax on medical device manufacturers, that can't realistically be done at the state level. And a levy on pharma companies be pretty hard to do at the state level. They taxed big health insurance companies based on their, I can't remember whether it's revenue or profitability. There was an extra tax levy on health insurers and pharma, and then a tax penalty on large employers who failed to provide coverage. So that was in Obamacare because they were retaining a private system in the market plans, and they were relying on large companies just to continue to provide health insurance. But you could, even if you had a single payer system at the state level, you could take the largest corporations in the state and try to tax them extra, but it's really hard for a state to do that because most of the states not only are not charging extra taxes to big companies, but they're giving tax breaks to attract them. I mean, think about why so many companies moved away from the Northeast and moved to the southern states. It's because they got tax breaks, very low taxes, and no unions, that their cost of doing business was going down. So it's going to be very hard for a single state trying to implement a state-based system to extra heavy tax larger corporations who they're already giving tax breaks to lure them to the state. That's not going to happen. It's just not going to happen. So the House of Representatives in the US, these were the taxes in a single payer bill at the national level from 2019. And notice here, I have here, the other taxes are the same sort of stuff we've talked about. But there is going to be a tax on stock and bond transactions. That every time somebody bought or sold a stock, that would be taxed, but it's really going to be hard for states to do that. Now this slide is the top five most important, is one of the top five most important slides in this internship. I've already shown it to you. And what this slide is showing is that from 1980 on the left to 2014 on the right, and if you go further beyond 14, it gets even worse. The upper line is health spending per capita, I'm sorry, as a percentage of GDP in the US. And all of those lines below are the other major developed countries. So when I talked about this slide before, I was saying, wow, the United States is a bizarre outlier. The other countries that look at the US and like they say, how do you do this? How can you be that inefficient? And so far in the internship, we talked about how we managed to be this inefficient. But now I want to draw attention to those lower lines. Because in some ways, this graph is the single biggest problem with state-based reform. And for those of you who study math, what's the slope of that line? Is it positive, negative, or is it zero? And this is, again, healthcare spending as it changes over time on compared to their GDP.
Positive slope.
It's a positive slope. And it's not like the one for the US, but it's positive. And what that means is that nobody, me, no one, the Dr. Friedman, who will be here later today, he's an economist. Nobody really knows how to kind of make this go away. The healthcare costs tend to rise as a percentage of GDP over time. Now, some of this has to do with aging, and as people get healthier, we have more elderly people. That'll probably get a little bit better as the baby boomers die off because the younger generations don't have that age distribution in their society. And so in places like Taiwan and Japan that are extremely old, Italy is another country that's very old and with low fertility rates, you'll tend to have positive slope for that reason, the demographic reason. But even if you leave demography aside, there are new inventions. Like, is AI really going to lower healthcare costs? Because that's not the history we've seen, is that you add new technologies and somehow they don't end up costing less. They end up adding to healthcare costs, and not just in the US. This is internationally. So this is a long-term problem, and it's one thing for a federal government to somehow put an extra, 0.25% onto their debt every year, or find a way to raise taxes. But a state government can't do that. State governments are legally not allowed to run deficits. So this positive slope is a really big problem, is that if a state managed to actually have an efficient system, and some of these countries have efficient systems, there still is this problem of unending tax increases. And I'm not saying I like the implication at the national level that our healthcare is just going to keep adding to our deficit or nationally based tax increases, because those are the choices. These countries either have to tax to pay for this, or they have to throw it onto their national deficit, which, their national debt, which is a topic of macroeconomics we're not going to cover in this internship, but it's a problem. And it's not beneficial to a country to keep increasing their national deficit, their national debt. And sometimes the problems come up suddenly, even though the national debt is accumulated gradually. So this can be a real problem. You've seen it more in poorer countries like Argentina, Greece, and some other countries, but we're not immune to having something really bad happen due to our deficit. So it's a big problem, but it's a national problem. As to a state, they have to tax for it, and what the state's quote single payer system is left with is an ever increasing discrepancy between the tax rates in that state and the tax rates in the state next door. Now, in some states like California, most of the state population doesn't live near a border, but in a lot of states they do. If you look at the demography, not just Vermont, but New York, New Jersey, Philadelphia, Delaware, people can cross the border very easily and even go to the same job. So you could argue then that Hawaii and California are better poised, and that may well be true, and probably all the states on the West Coast. But still, people can move, and people have been leaving California due to high costs of living and high taxes. So I don't think that the discrepancy in taxation is something to be taken lightly. The obvious thing the single payer advocates will say is, well, you're getting health care. Why aren't you willing to pay it? You're getting great health care. And we talked earlier, previous sessions, about all the people who would pay more in a single payer system and the people who may not want to, like healthy people. Because again, single payer systems, they tend to be progressively financed, and they tend to they greatly favor people who are sicker because they aren't losing so much money like they are now in the US. So Norway elected a progressive government in 2020. And the next year they tried to add a massive taxation on accumulated wealth of 11% annually. They were warned that such a move would trigger capital flight and threaten job creation. And unfortunately for Norway, it's exactly what happened. More super rich Norwegians left Norway in 2022 than in the previous 13 years combined. So people tend to not leave a state for a small tax increase, even rich people. But when you have an abrupt big tax increase, it may be a different story. So all over the world, rich people have found find these tax havens. You've heard of them all: Cayman Islands, Bermuda, Bahamas. These are, well-known tax havens where people can hide money and not have to pay taxes on it. And when I say people, I don't mean you or me. I mean people who really have money. And they know how to avoid taxes, and they find these places, in various parts of the world, and they take advantage of these tax breaks. Now, some states in the United States also can do this to a lesser extent, and South Dakota is known for this. And Delaware, of course, for corporations, a lot of them establish their headquarters there because they can get out of some taxes. But internationally, it's more effective to hide your money abroad. And so very wealthy people do that. So yeah, people do move their money, and in some situations, as in Norway, they're willing to move themselves. Well, at a state level, again, except for those 4 states in the far west of the United States, 5 states if you include Alaska, most people can pretty easily move and even keep the same job. So this is a real problem, is that people are mobile, whereas their healthcare system, if it's implemented in Vermont or New Jersey or wherever, the state is the state. It's not moving. So the people who support it can. And keep in mind the efforts of wealthy people to avoid taxation. Now, y'all think I'm from Vermont, and I am now, but I'm from Buffalo, and the Buffalo Bills are my football team, and nobody in Buffalo wants to lose their football team because cities have lost their football team. Cleveland lost the Browns about 20 years ago, and it was hard for them to get their team back. It went to Baltimore. Anyway, so the Bills wanted a new stadium completely financed by taxpayer money. So this is what wealthy corporations want. They don't want to pay big taxes. They want giveaways from states and to play off the states against each other. We'll move our stadium out of Buffalo. You're going to make us pay all these taxes? Fine. We'll move our corporate headquarters somewhere else. And so this is what we're seeing these days. So the real question I have is, with slowly growing healthcare costs, even in efficient systems, and this big tax differential between the pioneer states that implement state-based reform, will these rich people, can they be relied on to stay and pay $84,000 a year in New York or whatever it is? And I don't know if I trust them or not, but we need them to stay. So that's part one of the problem. Part two of the problem is whether we can, at the state level, gain the efficiencies of a nationally based single payer system so that we minimize the tax increase, minimize the spending. And so if you look at what single payer system can do nationally, we already talked about this, greatly sweep away administrative spending to very little, economies of purchasing, aligning infrastructure with public health needs, not having extra hospitals in cities just because they have capital to build one, and then they have to support that infrastructure. So all the dysfunctions you've heard about, so far in this internship, you sweep them away at the national level and you can be left with an efficient system. You can improve preventive care. You can greatly facilitate provider payment reform. So really, out of all of these things, the state could do number 3 and 4 on the list. They could try to prevent hospitals opening in places they aren't needed. The state government could try to do that. And they could improve preventive care and cover it for their population, which might save a little money. But really, it's number 1 and 2, and that are the big economies in single payer reform and provider payment reform, number 5 there, which is what Dr. Gaffney talked about. That's a pretty good cost control measure too. And it's going to be a lot harder for states to do that at the state level, but they could try to have global budgeting for hospitals, but the rest of this talk is going to explain why that's going to be really hard for the state to do. So in some ways, when you're talking about state funding of healthcare, the money is either coming from within the state, within Vermont. We fund our Medicaid program through the state portion of our Medicaid. Our uninsured people pay for care out of pocket, all of care. We have workers' comp here. We have auto insurers who operate in the state. They provide some care for injured people. It would take a huge effort to try to include them in the system. More on that later. We have self-funded in-state plans like Springfield Hospital you heard about the other day. They had a self-funded plan, so that's an internal plan. The state could say, well, get rid of your plan, we're going to start taxing you. And then we have a few private insurance companies. So those are internal sources of revenue, and they could be all abolished and transitioned over to the single payer system. But the external sources of funding, they can't be brought into our little single payer system in Vermont so very easily. And we need that money. That's more than half the money for Vermont's healthcare system. Undoubtedly the case for every state. That there's these multi-state companies, FedEx, Walmart, who provide coverage for some of their populations, and they are covered through a national law. They're exempt from state insurance regulation, but they provide insurance to their employees. So the question is, if we create this state-based system, are they going to voluntarily just abandon the plan that they have in place for the other 49 states and just say, sure, Vermont, we'll pay however much you want, and you go ahead and run the system for our dinky percentage of employees who work in Vermont. It's more administrative work for them, and it may be more costly. So the question is Walmart going to want to pay? So we could tax them. Maybe that would work for Walmart, that they'd pay the higher taxes, presumably raise their prices. But, you know, a company like IBM could just pull more jobs out of Vermont than they've already pulled out of our state. If they're going to, you know, if they don't want to do this for whatever reason, it increases their taxes, and, you know, their own plan was cheaper to provide. A lot of their employees might have been declining, which really made it cheap for them. You know, a lot of employees decline coverage. You know, we've talked about this before. 15–20% of employees offered health coverage refuse it. Either they can't afford it, or they're hopefully getting coverage for their spouse, but a lot of them just are uninsured. So external sources of funding we really want to maintain, and that includes Medicare money from the federal government, the federal portions of Medicaid. We need that money. The Medicaid program just has us get that through billing one person at a time, or making a deal with a private insurance company, which we're obviously not going to do in a state-based single payer system. That's the whole point, is create a single system the best we can. So the VA and the Indian Health Service, they get money from the federal government. The active military are funded through their coverage. I think it's called CHAMPUS. So we need that money. And then a big one is all the people who get care in Vermont who don't really live here. So there's two subpopulations of this. One are the people who really don't live here. So across Lake Champlain is a section of New York State that's very sparsely populated called the Adirondack region. Adirondack Mountains are beautiful. I'm actually going to partly be moving over there soon. And it's very sparsely populated. There aren't many doctors, or not a lot of healthcare. So they use Burlington, Vermont as their tertiary care center. So a whole lot of those people come to Vermont for their healthcare. So if these Adirondack people are getting their healthcare in Vermont, and we want our hospitals to get rid of their billings departments and only have the state health insurance fund as their source of funds, what are we saying to these people in the Adirondacks? We're going to give you all your care for free? And what about all the skiers who break their femur skiing at our ski resorts, and we take care of them? You know, big operations sometimes to do a, you know, femur tib-fib fracture. We had a hip fracture at the end of the last skiing season at my hospital. You know, we're going to provide this care for free out of the state insurance fund, so we have a nice, efficient, you know, administratively efficient billing system. Well, I don't think so. So we've got all these people. We've got snowbirds who are here for 3 or 4 months out of the year, you know, and have Florida or Arizona as their primary residence. So we're not going to bill when we take care of them. I mean, I take care of a lot of those people, and, you know, I mean, the idea to me is distasteful. That's how we get some of our revenue to support our healthcare system. So 18% of hospital care in Vermont is provided to these external people. And if you threw in Medicare and Medicaid, then it would be even that much higher. So this is a real problem for states. They don't want to, none of their healthcare facilities are going to want to forego this income, since it might be a whole lot percentage. Like if you were in New York City, or, you know, even in California, where they have, you know, renowned medical centers, or, you know, major referral centers in Dallas and Houston, if people are coming from Oklahoma and Louisiana to use the care at the huge cancer center, Anderson Cancer Center in Dallas, are they going to not want to be paid for it? So these hospitals are not going to abolish their billing departments. They're going to want to get paid. So the administrative savings is greatly compromised. Now, the question is, there are some big things. So here are some of the threats. Within the private sector are the multi-state companies who may not want to participate in your system. And businesses in general can threaten to lay off employees or move to other states when they're suddenly facing a new tax. Keep in mind the 30-hour per week rule of Obamacare, that big companies only needed to provide coverage within Obamacare if employees worked 30 hours a week. So suddenly they had all these employees who were working 29 and they didn't have to provide coverage for them. So big companies often don't do the right thing, quote. So the national law that allows these multi-state companies to be exempt is called ERISA, and there'll undoubtedly be a lawsuit for these multi-state companies who don't want to participate in, whether it's in Vermont or California or, wherever it is. So then there's a public sector issue, is that to get Medicaid money, you gotta make sure you're enrolling people who qualify for Medicaid. And you have to make sure they're getting a certain set of services, like child screening, and other kinds of services. Well, we're fine with the services. We're going to do those for kids and we're going to do pap smears. But eligibility is an issue, that in the Medicaid program, you have to show that each person who's funded that way is actually eligible. So the federal government's not going to say, well, you've got a single payer system, it's going to be fabulous, so we're just going to pay you a lot more. And we're not going to keep track of this. No. They're going to want to know how many people in Vermont or wherever the state is qualify for Medicaid and give that, that match, whatever it is. In Vermont, it's 56%. Mississippi, it was 72%. So they're going to only match the people who qualify, because the other states are not going to sit by if they're overpaying Vermont for its little single payer experiment. So we'll be granted a Medicare waiver too, so that we don't have to bill a la carte for Medicare. We'll be allowed to abolish the Medicare Advantage people, that they're going to be out of their Medicare Advantage plans, whether they want to or not. They're going to be enrolled in the system. Also true at the federal level if we have single payer at the national level, but at least there you're throwing them out of a Medicare Advantage plan and throwing them immediately into, a high quality Medicare for all system with good coverage. Whereas here they're just getting into some Vermont scheme, and they might want to stay in their Medicare Advantage plan. So the federal government may or may not let us do this with a waiver. And then we have federal employees at our airports, transportation security and the postal workers and the federal judiciary. We've got a lot of federal employees in Vermont and every single state, and the military. In some states, there's a whole lot of military people. Are they going to be adding to the complexity, or are you going to really have them in a single payer system? So Medicaid, eligibility determination, I'll just skip over this. Medicare, same thing. We want what's called a waiver, where the federal government makes a fair estimate of what they think our Medicare and our Medicaid populations will be costing, and just give us that money so we don't have to do it a la carte. But that's a big deal to give us a waiver, and there's not a precedent for it, and may or may not go well. Obama refused to give us the waiver when we passed our plan. Whether Trump would have given it, you can only guess. So out-of-state sources of funds, again, we talked about, some of them are in the public sector. I just talked about those. And then in the private sector, there's even more. Retiree coverage from out of state. I have a personal friend who worked in Connecticut as a teacher her whole career, and in lieu of having a higher salary, the teachers union there gave them fabulous retiree benefits. Okay, so now she's here in Vermont getting these retiree benefits from the Connecticut school system, and she doesn't want to pay her share into a state-based system because she's got this better coverage. And the same thing for state employees. Many of them have really good coverage. They may not want to suddenly have to cough up, whatever their taxes would be. So these are all issues at the state level, and you need all this money. Like her Connecticut money's coming into Vermont every time she goes to a doctor. We don't want to suddenly say, okay, Connecticut, we don't want your money anymore. We want it. We need that money. She's getting care. That's one of the ways our health system is funded. We want it. Okay, so then what about another issue is, yeah, let me go on. So Medicare supplemental policies, those policies will be replaced with taxes. And for those who have supplemental policies funded by out-of-state sources, they may not be very happy about this, like this woman is not. So Medicare Advantage and Part D coverage both would be prohibited and abolished. Again, how that would go at the state level, unclear. Military, we talked about. Other federal employees, they may have a lot of anxiety about being tossed into a untried state plan, might generate a lot of opposition. And then the care to be provided to out-of-staters we talked about. Now let's get into this a little bit, and this will be the end. Vermonters who work in other states. So let's say someone in Vermont works across the Connecticut River at Dartmouth, and they get their insurance as an employee of Dartmouth. So when that person goes to their doctor in Vermont, the doctor then bills Dartmouth's college's insurer, and they get paid. Same thing if the person needed hospital care. But if we suddenly pass a universal health care where every single resident of Vermont has coverage, why should Dartmouth College pay anything? Their employee already has coverage through their state system. So why pay anything? And I don't know if you knew this, but a lot of companies literally pay $500 to every employee that they have on their payroll who refuses health coverage. It's kind of disgusting and undermines healthcare funding, but that's reality. So Dartmouth could say, okay, all you Vermonters will give you $500. You don't need our coverage, forget it. You're in Vermont, you've got that state-based system. So this money that was coming into our healthcare system from Dartmouth is now shut off, and we've lost it, and we have no recourse over them. Now, it's a limited number of employees, but if you add on multi-state companies, people who began living in Vermont, but working in New York City or elsewhere, based companies, people who do their work in Vermont, who are getting insured from out of state, that can start to add up. So this is a threat to our system, losing some funding for our system. The opposite of that are out-of-staters who work in Vermont, and that's an issue too. So Vermont employers need to be taxed based on the number of employees and not the number of Vermont employees, because if they're not taxed for everybody they hire from surrounding states or elsewhere, then they're going to have a big incentive to stop hiring Vermonters at our own companies. So they have to pay based on their number of employees. Okay, so if their employees are going to work in Vermont and they've been getting their coverage through a Vermont employer, and we're getting rid of Vermont-based coverage, then basically the health insurance system in Vermont, our little single-payer system's going to have to pay these out-of-state people to get the care where they usually get their care, which is probably out of state where they live. So this is another complexity that's added into this state-based insurer. So this is a lot of complexity. There's a lot of threats on not being funded properly. And I didn't talk about workers' comp. It's kind of the same deal. Workers' comp provides health coverage. And so, how do we get the medical portion of workers' comp to not be separate so that we don't have separate billing systems for every injured worker? Same works out for people with auto wrecks. They get funded through their auto wreck insurance, automobile insurance, And it's just more complexity. So we've got all this complexity in the system. At the national level, it would just get swept away because it would have to be. I mean, in a national system, why would you keep all this stuff separate? But at a state level, it's just going to be a little harder to sweep all this stuff away. And so this is why I'm nervous. It's not the big picture. The big picture, in theory, it works out really well. But you get into these details and I start to worry. And I guess finally, anyway, this is my big problem is that, okay, if a university closes down or there's some important failure, yeah, the students would be hurt, the faculty members would lose their job. But the failure of a state-based, quote, single payer system, when costs are rising, they can't really reduce administrative costs. They don't really have power. If Vermont or even California sits down with drug companies and says, we don't want to pay so much anymore, that pharmaceuticals company going to look at them and say, look, we don't want your system to work. We want it to fail. So we're not compromising at all. So reducing prices, reducing administrative costs are going to be really tough. And so this tax increase could really kind of go up and up. And if you really swept away everything else, it may be hard to recoup, and the state will have a huge debt load on its debt for a long time. And if this ruined the credit rating of a state, this would be a big problem. This happened in New York City in the late 1970s, and it was a big deal. They asked to be bailed out by the federal government, but, did the federal government really want to do that? Because that might encourage other cities and states to overspend. So, furthermore, this failure would not only be financially catastrophic for a state, but just imagine. I mean, when Governor Shumlin withdrew our plan in 2014, it made national headlines, and suddenly the media were asking Bernie Sanders, oh, you're the big supporter of single payer reform. You can't even get it done in your own state. And he literally had no response. All he said was, well, they didn't really try it. He didn't go through this level of detail because it would have been politically difficult, or might not even know it all. I don't know. But anyway, so this is more like a Gulliver failure where there's one little reason after the next, and they build up one after the next, shutting off the needed funding for a state-based system. So this is what I'm nervous about state level reform. But I am really sympathetic to people who work on it. I'm frustrated too. So I'm going to open it for questions for the next 5 minutes, and then we'll take a 15-minute break. Restart at 11. So any questions in the next few minutes?
I feel like part of what I'm kind of hearing from people talking about these state-based reforms is that there's this thought that if enough states do it, it will just become national policy, which I know is like kind of what happened in Canada, but there's also a lot more states than there are whatever their state equivalent is in Canada, right? Um, I'm just wondering, like, do you think that that is a possibility that it could actually work that way? Phoning in from south of the Mason-Dixon line, I have my doubts, but I was just wondering, do you think that that domino effect is something that could actually be seen with state-based reform?
Well, if it could succeed in the first state, yes. I think it could happen. I think Anna is going to argue against that at 11 o'clock, so I'll leave that to her. But I mean, I think it could happen that way, that Idaho Care, if it succeeded, could become Montana Care and Colorado Care. But my worry is that the first state won't succeed. But you're right, the Saskatchewan effect in 1946 was great, but again, the big difference was that the amounts of money were so much smaller. And Canada never had the kind of complexity we have in this country. It's a friggin' scramble. When patients we had a speaker earlier in this internship who was sort of encouraging, I think it might have been Weisbart, who's sort of viewing it as a little victory when people get out of Medicare Advantage plans. I say to patients, just figure out the easiest, the most financially beneficial way to get coverage that seems good, that is good. Look into it carefully. But it's a scramble in the United States. It's a big game of musical chairs. Do the best you can. So it's just complex, and to sweep away the complexity, there are federally based obstacles that are trans-state, that go beyond state, interstate, that go beyond state borders. And they're my nerve, both in the private and public sectors. And that's what I worry about so much.